again to guide us on various surgical skills through a plethora of his experience, and so interesting the way he teaches us. I think this will again open up our mind, and I know the way we had conducted the earlier two sessions, this session will also help us in bringing out a lot of clarity on surgical skills. So, as we earlier discussed in the first two series, we have covered on surgical skill transfers, and we have seen that surgical skill transfer in 21st century, and then we have seen cesarean section, what's new in that. And today our main focus will be on solving the clinical dilemmas. So, without wasting much of time between you and Dr. Mohapatra, I would like to hand over to him only after this announcement that this particular session, we will be covering all your queries in detail, and whatever queries were left in the last session, we'll try to figure out those also. So with these few words, we go ahead with Dr. Mahapatra. Sir, please guide us on the surgical skills. Thank you. Dr. Mahapatra, please.
Thank you very much, Dr. Diwan and Team Juventus, with the leader of the session, Alad Mahajan, and other people across the country. And welcome all my viewers, all my fellow gynecologists, my colleagues, my friends, my students, my grand students, and everybody in this particular session of e-Gurukul, which is a Juventus initiative for that. When they told about this during the Corona pandemic, I told that enough of a webinar day in and day out. It is going on, and particularly on weekends. It is absolutely from morning to evening, the webinars are full. So are we going for academic obesity? I think I told them that to refrain from academic obesity, but they insisted that it's not in pure academics, but the teaching. And the passion for teaching is there with me for long, as a teacher for last 40 years. I have a passion for teaching, and I couldn't resist their request. And that is the genesis of this e-Gurukul program, which is there. And we have already finished the 2 episodes of this. And today, again, my sincere apology to all my viewers that last time, due to technical problem, we couldn't complete the 2nd episode. And I was about to tell about the clinical dilemmas. There I have fragmented into 3 different segments. The first segment, I have already enumerated my surgical skill and the video in which I practiced cesarean section and demonstrated the video. The second segment is from the time of anesthesia. What will be the problem that can occur till the end of the surgery and even post-operative, and late remote complications also I have just theoretically enumerated. And today is really a solving clinical dilemmas which I have personally experienced. I will share with you over the last 4 decades. I have personally experienced some of the problem. I'm put forwarding these particular thing for that. And as we know, cesarean section is a very common operations by obstetricians and gynecologists, from the rural to urban to metros to everybody. I think the main purpose is that safety. Safe cesarean section is the main criteria, where we want a healthy mother with a healthy baby for that. That's a major thing which comes down for that. And therefore, in surgical techniques is most important while dealing with this cesarean section. And preventive surgery is most important. It is not a credit to manage to create complications and manage complications, but it's a credit certainly to prevent complications for that also. Do it and forget it. That should be the motto for that. I think the post-operative, I always tell, the most important post-operative care is a good piece of surgery. Majority of the complications post-operative is traced back to the surgery. And therefore, you do it and forget it, and just pray God and start this surgery and almost forget about it for that. So with this, apology. I'm just continuing the third episode, and I've told the Juventus Alad and other team, Juventus team, to support you if at all somebody requires these two earlier episodes. That will be complete on that particular surgery for that. And every fortnightly, whatever we do that surgical session, the first session will be a surgical session, and second, the clinical solving the dilemmas which is evolving around that particular, we will discuss. And that will give a lot of satisfaction to me that I have done something for my students, something for my fellow mates or fellow gynecologists for that. And I don't consider myself that it is something which is unique, but in which way I have done more number of mistakes than anybody in the country also, because I see for the last 40 years I do a lot of mistakes, and I have learned many things from my lessons learned from my mistake. And I believe that I should ventilate my mistakes, not that I will just propagate my success. That is absolutely wrong. I don't believe in that. You always say that whatever mistakes you say, and then you must share it so that the other people will not do the same mistake, and then things will be all right. And that for the patient, benefit of the patient, as well as for the skill development, this is absolutely essential for that. With these few words, let me start this third episode of e-Gurukul, which is a Juventus initiative for that. And therefore, I welcome everybody to this particular episode, which is unique. And thanks to Juventus and whole team under Alad, under PK Goa and Diwan, which is there. And welcome to the episode 3 and surgical skill transfer and solving clinical dilemmas for that. And therefore, this is the thing mainly evolving around that. There are a lot of queries in cesarean section. Believe me, I'm reminded 20 years back, my professor asked me, which is the difficult surgery which you faced it in my earlier days when I was a assistant professor for that. I replied to the professor, madam, the most difficult in major surgery is cesarean section, and in minor surgery is suction evacuation. These two surgery, I'm really afraid of that. While going to that, I pray God and do that. Then he told, it's a, how you say that? I told, madam, this is truth. I have experienced that. I am not skeptical, or I'm not afraid of doing a Verdim's hysterectomy, but I'm really afraid of doing a cesarean section, because many of the unpredictable complications can occur around it, and many of these skills has to be acquired, which has to be practiced to prevent the complications for that, so that the life of the mother and the life of the baby can be saved. Not only the mortality, the morbidity is also an important part for that. Do a good surgery. I think the next time the repeat section will be same as a primary section for that. That's my motto for that. And that is the main purpose for this today's, mainly the third episode, dealing with situation analysis. I'll put forward a few situation analysis, very common, which is a real life history of I have been associated. And that I always say that introspect. If there is a wrong thing, introspect, scientific analysis, and action with confidence, you have to give it for that. I do. Now, this is a situation one where long back, I don't remember how many decades before this has happened for that. Is a Mrs. X, G2P1, post-cesarean pregnancy. It is a short-statured lady, 38 years, and cesarean was done for CPD 4 years ago. I have seen the discharge ticket of the previous cesarean, which is done elsewhere, CPD, indication was CPD, and with a healthy female baby of birth weight 2.8 kg. Now in this pregnancy, normal fetal growth profile, vertex presentation, 5/5, estimated fetal birth weight is 3.2 kg. At that time, Johnson's formula was applied, and clinically the normal growth pattern is normal, and apparently normal clinical pelvimetry. I've done a pelvic assessment, and pelvic assessment couldn't find any abnormality for that, and therefore planned for elective cesarean on 20th of December. Because of the indications, this is a recurrent indication, 38 years, post-cesarean pregnancy, done for a recurrent indications like CPD, and age is 38 years, short stature. So what else we require for that? The indication is enough, and therefore plan for elective cesarean section on 20th December. But unfortunately, she went into spontaneous onset of labor on 19th midnight, hospitalized, and a spontaneous vaginal delivery with a male baby by midwife weighing 3.3 kg without any maternal or fetal complications before I could reach there. I felt very ashamed for that. This could be a common situation. Some of you must have noticed in your own experience like this also. Then I think let us discuss this particular case. What is wrong? Is it a wrong decision? I think decision is wrong for that, number one. And how to deal with such situations? These are the two issues which I will just enumerate here. Is it a wrong decision? I think as far as indications are concerned, indications of cesarean section and decision for cesarean section, these are the two things which is necessary, because in view of now we are discussing, now there is really a message that are we going for increasing cesarean section? Is there a need for reducing the cesarean section? That is a topic of discussion since last 4-5 years. And fixing a percentage is a different issue. I think government cannot say that, an agency cannot say that you do it, 15% will be target for that also. That's not, I don't accept that. But certainly we are doing an increase in cesarean section. There is an increasing incidence of doing a cesarean section. There is no doubt about it. Everybody must be agreement. Is it good or not? There is a debate which is going on, and you people must be aware of that. Why there is an increase? Because of medical legal, because of women's choice, because of several reasons that is there. But it's not that they will blame for commercial purpose. People cannot blame gynecologists for doing an increased cesarean section for that. This is one incision. So decision again, indications again. I remember that 15 years back when I was going as an examiner and asking the postgraduates what are the indications of cesarean section, and beautifully describing fetal indication, maternal indication, recurrent indication, non-recurrent cause, everything beautifully. Now, if I go and ask an examiner as an examiner and ask the examinee that what is the indication of cesarean section, very simply and straightforward answer, one sentence they will say, presence of pregnancy is an indication of cesarean section, sir. I told obstetrics has become very simplified. It is a terroristic obstetrics view, or it is a rational obstetrics view. You analyze therefore that. So what I mean to say that the incidence is gradually increasing because of some pretty unexplained reasons for that also. This is one aspect. Now, second aspect in this particular case. Now, the previous indication was CPD. Then I analyzed what is CPD, whether C is defective, the cephalic is defective, or P, the pelvis is defective, or D, doctor is defective. I think doctor is defective, because we know that this is a case where even if short statured and 2.8 kg baby delivered by vaginal route previously, now in post-cesarean has delivered about 3.2 kg baby, and normally without any assistance and before the consultant could reach. I think the D is defective. The difficulty, I think the difficulty of leveling as a case of CPD. This is absolutely genuine. How to deal with such? This is there because the assessment criteria of cephalopelvic disproportion is $1 million question for that. We always teach students that the pelvic assessment, you introduce your 2 fingers, go and reach the sacral promontory, then the side walls, then the ischial spines, and then interspinous diameter, then the outlet. You measure it and then find out that the pelvis is normal. Now, then how to say that this pelvis is normal for that particular head? It is a retrospective diagnosis. When the delivery is there, then we can say that this head and this fetus has been negotiated well in that particular pelvis for that. And therefore, we know that pelvis is not symmetrical, it is asymmetrical, because the human pelvis in comparison to the veterinary animal, it is different. It is around veterinary animal because of the quadrupeds, because of the bipedal attitude of the human being. The adult female pelvis is having an asymmetry. When we go to the brim, we find that the transverse diameter is widened and the anteroposterior diameter is short. When we go to the outlet, we find that the transverse diameter is short and anteroposterior diameter is more, so that the mechanism of internal rotation, restitution, and external rotation is there for a complete negotiation. So this negotiation is successful, we know, retrospective. But how can we say by clinical examination that this particular head can do? Even if there are a lot of head fitting test, Mundakar test, Yeah, Donald test, we teach students for that. But it is a $1,000,000 question, believe me. CPD, the pelvic assessment is difficulty, inaccuracy. And how to deal with such situations? Because you feel embarrassed. You have given a patient has lost confidence on you. So therefore, you have to have look at that particular aspect for them. So these are the few aspects which you will. So many people say obstetrics is unpredictable. I think you don't, even with where booster antenna, you are not able to find out the solution. There are many unknown factors which is there. I know it, but you cannot say that you cannot escape, and this cannot be a complacent attitude that obstetrics is unpredictable. It is predictable. And here what is happening? There are multiple variables in the birth process. Here in this particular thing, there are two things. One is a scar, another is a pelvis. Pelvis, regarding pelvis, I have enumerated that as adequate assessment of the clinical assessment of the pelvis is difficult, particularly in by clinical methods. And biophysical assessment of the fetus is also where even with color Doppler and all that, there's a lot of inaccuracy that we have to admit for that. And regarding the scar integrity is absolutely a misnomer for that. Many people say that scar tenderness for that. But scar tenderness, if it is a scar tenderness, it's an impending rupture. If there is associated with the bleeding or a bloodstream discharge along with tenderness, if you find suprapubically, then you can suspect it. Otherwise, the integrity of the scar, very, very difficult. Even by ultrasound, there are a lot of papers which have been thickness of the scar. The thicknesses are not always related to integrity for that. Even thin scars are better. Thick scars can be ruptured for that. So scar integrity is a very important issue. It is still debatable issues for that. And last but not the least is an obstetrician's bias, emotions, and luck. I think this particular case, I believe that luck factor is also an important part, because the patient lost confidence in me that he has told the cesarean section, it is not possible, but I have delivered it. I lose confidence on the particular doctor for that. I always say obstetric practice, the luck factor is very, very important. And there is a permutation and combination. Lucky obstetricians, lucky patient, excellent prognosis. Unlucky obstetrician, unlucky patient, worst prognosis. Lucky obstetricians, unlucky patient, and unlucky obstetrician, lucky patient, it is a mixed prognosis will be there for that. And one of the important thing, bias and emotions in obstetric practice gives rise to active mismanagement of labor. And what I say, bias and emotions, giving a simple example for that. Suppose you have delivered a patient where absolutely after delivery, you find that the baby is meconium stained and it's a birth asphyxia, baby could not be revived. It is a great shock to the obstetrician. And next week, suppose you find a patient where again the progress is not normal, progress is going on at 6 or 8 centimeter dilated, you rupture the membrane, you find light meconium stain like that. Even if the progress is normal, even if the fetal heart is normal, because of the previous incidence of losing a baby, there is a tendency of doing a cesarean section immediately. You don't allow for a vaginal delivery. So this bias and emotions, human being should not have been there. Particularly, they should know, but they cannot say that this bias and emotions to be reflected on decision making in subsequent case for that. So this is the ultimate, the dilemmas which evolved around it and how to have a solution in different angles. If you make it, I think things will be all right for that. So the tips and tricks is that expect the unexpected, always expect the unexpected, assess and reassess. Don't say that you cannot deliver it, and assess. You can say that yes, we will have again decision in CPD. That's why we say that CPD assessment in labor has to be again reassessed. If suppose you have done in pregnancy, late pregnancy, you have to again reassess during labor for that. And of course, communication and counseling, so that the person will not lose confidence on you. You detail that this is possible, and counseling is important for that. That you cannot say that it's impossible. Nothing is impossible. You can say that the problem is there, that's why I'm going for a cesarean section. You may not, you may again, when you have a pain, then I will again reassess and find it for that. And learn from others' mistake and gain from your mistake. People say that learn from your mistake. I have a different opinion for that. If you learn from your mistake, you do the mistake and learn from it, and whole life will be spent in doing mistake and learning. You cannot gain it. So better if during your own lifespan, if you want to improve, you learn from others' mistake and gain from your mistake, so that during your lifespan you can do something for that. And last but not the least is introspection. Always introspect. If there is something wrong, you think about it, introspect why this has happened, and you can find out tips and tricks for solutions for that, and the problem can be solved for that. Situation 2. This again related to some of the cases where it's a practical thing, which a real life story of mine I'm presenting here. Third gravida, para 2, leaving 1. Previous 2 LSCS. First was an LSCS, term male baby, could not be revived. Second was an LSCS, which is elective, and a female baby of 2.9 kg living. And third, she presented with secondary infertility. Then I conceived following investigation for second. I've done a hysteroscopic tubal cannulation, and she conceived having a regular ANC, no risk factor, normal fetal biophysical profile, color Doppler normal, and decision for elective cesarean section was done on 18th of February when it was 38th week. On 18th February, I gave a date that on 38th week, in consultation with the patient, everything was normal. And this was the second previous 2 cesarean section, and that was the right indication for cesarean, and one living issue was there, conceived following investigation for infertility, and therefore I accepted, and the date has been fixed, time has been fixed, everything has been fixed. And after that, after 2 hours, the mother-in-law came. The patient came with the mother. Then after 2 hours again, the mother-in-law came and approached me and opted and wanted to change the date a little and fixed a time as advised by Baba on 20th of February. Do it instead of 18th February, do it on 20th of February. So 38 weeks, 2 days. He wanted to take time for 2 days more. And this is only by the Babas. So because of the muhurtam and all that, people believe in that. And I agreed, because there is no technical contraindication for that. Had it been IUGR, had it been some oligomnias, I would not have agreed for that. But I agreed to it, unfortunately. On 19th of February, patient had an episode of mild bleeding PV. And on examination, uterus relaxed, normotensive, fetal heart not localized, and sonography demonstrated intrauterine fetal death. I was shocked. I was really shocked when I find this and all that. And what is your comments? Then I thought, what is your comments? What's wrong with the obstetrician? Whether I've done a wrong thing by changing the dates? And what's wrong with the patient? What's wrong with the patient? And then these are the tips and tricks. This is an accident which has taken place. Accidents can happen, but it's a coincidence which is more painful for the obstetrician. This is a very painful thing for that. And therefore, from that day onwards, it was long back, about 15 years back, this was the situation. And from that day, I believe that decision versus deviation. Baba is not supreme. Baba, because the Baba patient lost a male baby for that. And decision versus deviation. I have deviated. I have decided for one day, stick to it for that. Even if there is no technical contraindication for that. I have many other examples for that. I will advise all of you, share with you some of the facts. A patient came was decided for elective cesarean section and previous cesarean, and given a date for that. And she presented with pain abdomen before the scheduled date at around 12 o'clock midnight. Patient was admitted in the hospital. The patient was having a mild uterine contractions, and it was not absolutely, she was not in labor, cervix long, os closed, and but uterus is irritable, and patient was complaining of little painful uterine contractions. Then my staff told that yes, we'll do it, and tomorrow morning we'll do it. I think from that day, after lesson that I didn't shift in the morning hour, even with the difficulty in the dead of night, I did it same night. And unfortunately, I find it was a mechanism stand liker, but the baby could be survived for that. I repented that day that that previous case gave a lesson to me. If you have decided, do it for that. And remember, my fellow members, this is a common situation which all of you must have faced for that. And many of the cases where I have seen the uterus is irritable at beyond 34, 36 weeks for that, uterus irritable, and it is not, you give a analgesic and patient is not improved, little pain is relieved, again it is there. Those are difficult cases. If the pain is continuing, but it is not progressing, cervical dilatation is not there, These are your example of fetal distress. That could be fetal demise if you do not be very serious for that. This is another indication which no books have written, but this is the real practical situations I have learnt it for that. And that's why I want to convey this. Now, situation 3, primary gravida, 32 years, conceived following investigation for primary infertility 8 years. IVF conception. Husband is an IPS officer and wife is a journalist. Very terrible combination. I think you imagine when the husband is an IPS officer, wife is a journalist, and you are the treating obstetrician, treating doctor, how difficult it is to be that and VVIP. Twin pregnancy, regular ANC, and bleeding at 11th week, treated conservatively. And TIFA scan, normal scan, normotensive, admitted with preterm labor at 31st week. Hospitalized, given betamethasone, nifedipine, rest, repeat sonography, revealed normal biophysical profile. And discharged after 1 week, that is on 32nd week, and counseled to undergo elective cesarean. I didn't want to take it to the term. Before term, 36th week, I decided that after 2 weeks, I will do a cesarean section, elective cesarean, given a date for that. And I told that even with that, after 1 week, you again come and I will reassess and do a repeat scan for that. Unfortunately, she didn't come after 1 week, and that in that way I have been saved for that, because the blame otherwise they would have given for that. Instead of 1 week, they came after 10 days, 2 weeks after, readmitted after 2 weeks. That is about 34th week with an episode, because there is an episode of mild bleeding PV, and BP was 140/90, uterus tense, tender, FHS not localized, no active bleeding, and urinal windmill. And sonography reveals twin fetuses, 33.2 weeks, 34.1 weeks, IUFD, bivertex. Both the fetus died with the 2.2 kg and 2.4 kg, placenta upper segment, no evidence of retroplacental clot. I think this is really a shocking news to me. That then I thought whether my decision was wrong. I would have done 34th week cesarean section for that. What wrong with the patient? Wrong with the patient is she didn't come after 1 week. That's why. That has saved me for that. And what's wrong with the obstetrician? Wrong with the obstetrician, retrospectively, you can say that if I would have been a bias, I would have done all cesarean section and IVF pregnancy at 34th week. It is not science. It is not rational. Don't advise for that. So it is just obstetric bias and emotions for that also. So it is a bad luck of mine. And because I am a unlucky obstetrician with the unlucky patient, this has happened to me. What could have been done to save the babies? Babies could have been, suppose I would have done retrospectively, I find that at 34th week, if I would have done a cesarean section, then I would have saved a baby for that also. But on what basis the indication should be there for that? That's $1 million question. And what next? So the tips and tricks. IVF pregnancy is luck, but to have a baby is a destiny. And even with the best practice, such things can happen. Prevention and prediction is $1 million question. Early intervention is justified, but only on retrospective thought. And counseling, communicating bad news and after effect, you know it, and everybody must have realized that. And next pregnancy, what are the possibilities? I think God only knows what is the possibility of the next pregnancy and the next outcome for that also. Situation 4. Mrs. X, G2P1, post-cesarean pregnancy. History of abdominal sling operation for nulliparous prolapse. At that time, the Purandare sling operation was done open. It was not a laparoscopic sling surgery. And then she conceived. She has a cesarean section. Last childbirth was 3 years. And this was a second pregnancy. It was a plan for elective cesarean section at 39 weeks. Sonography was done, single live fetus, cephalic. Estimated birth weight is 3 kg. Normal biophysical profile. Placenta was upper segment. But the indication was a G2P1, post-cesarean pregnancy, and previous sling operation. So there are two surgeries. One is a sling operation, there is a laparotomy, and another is a cesarean section for that. So first and foremost, I'll find out anticipation and planning. Remember, again, I'm emphasizing, as a surgeon, all of you must give emphasis to the surgical planning. Nobody is giving, very rarely people give importance to the planning, pre-operative planning for that also. and they do the surgery, and then and there, if difficulty arises, then they decide for that also. I think that's wrong. You must find out a mental preparations for that. What is expecting this particular case? Every case is different with every case. So what difficulties I will anticipate in that particular case, and if that difficulty will anticipate, how I will tackle it. I think that is very important. So this anticipation and planning is important thing for that, and therefore this particular case, what anticipation I require it. Now anticipation number one is that the hemorrhage bleeding. I anticipate a bleeding. I anticipate a altered anatomy. Then about that third important is about the bladder, injury to the bladder. So these are the three main important things I kept in mind for that. So accordingly, a suprapubic incision was given, and oozing from parietal wall controlled with cautery, because this is a boon nowadays for surgeons. There was adhesion of rectus sheath. As we know, this is post nulliparous pull-off sling operation that is expected, and previous cesarean moreover after that. And separate, always separate by sharp dissection. Don't have a blunt dissection on that, because these particular adhesions are not dissectable well, and separated by always use a sharp dissection and sharp dissection. And if there is a bleeding, use the cautery for that also. Now I find that the parietal peritoneum was fixed to the uterus. I couldn't enter into the failure to enter into the peritoneal cavity. Some of you must have encountered this type of cases where you difficult in entering the peritoneum and cavity, peritoneal cavity, and therefore failure to enter into the peritoneal cavity. Even at the highest point, remember, you always select the highest point, keeping bladder into view for that. If you make it a highest point, I think the bladder can be safeguarded for that also. So lower segment was adherent. I find that the lower segment was adherent to the parietal wall, and I find an old scar in the lower segment which was found, and that is a fortunate for me that I could identify the old scar which was completely adherent. Parietal peritoneum was not found out at all, and it was a complete ventrifixation of the pregnant uterus to the anterior parietal wall. And then on the incision on the scar, I didn't separate the bladder, because at that stage, usually you restrict separating the bladder dissection, because it will be liable to cause bleeding, as well as you cannot find a good cleavage, and there is a risk of bladder injury for that also. So incision on the scar was given, and don't have a blunt stripping of the scar. I always use a curved scissor dissection. Scissor dissection and a curved incision on either side, and therefore then applied vacuum delivery. I always apply vacuum extraction of the head and deliver the baby. Ecbolics was given, afterwards extracted, and then lower age of the uterus was identified. After the delivery of the baby and afterwards, lower age of the uterus was identified, lower flap. Then the bladder was dissected. And remember, the bladder dissection always do not go from midline to lateral, always reverse. In bladder dissection, always from lateral to midline, because still we believe that the lateral windows, laterally the bladder is least attached to the uterus and cervix, and therefore you can find a good cleavage, plane of cleavage, and it could be very well for that. And don't over dissect the bladder. Whatever is required for apposition of the uterine muscle in 2 layers, that is enough for that also. So I always advise, don't go more than 2 centimeters lower down. More you go, more the bleeding for that also. And there we find that the nulliparous pull-off sling operation and the fixation point is in the lower cervix, and there will be more bleeding. You cannot get it, and that causes a lot of problem for that. And uterus repaired in 2 layers, and with hemostasis, always with hemostasis. After that, you find out, because after the uterus is in sync to a considerable reduced size, then you can find out and can find out a cleavage to the peritoneum. You may not get it, but if you get it, then you can correct it, the cleavage. If you don't get it, don't worry about it. After the good hemostasis, use oppose the muscle, oppose the rectus sheath, and with or without the drain, you can close it, and there cannot be any problem for that. Now, what are the tips and tricks? I find already told that anticipation of adhesion, oozing, difficult dissectability. This is one. Hemostasis is absolutely important. And attempt peritoneal entry at a higher level to avoid bladder injury. Failure to entry or finding cleavage, identifying the bladder anatomy is important. Finding previous scar, incision over the scar, delivery of the baby with vacuum, separation of bladder from lower edge, no undue dissection, as I have already told, and closure with hemostasis, and drain as and when required. So these tips and tricks can reduce the lot of problem post-operative. Situation 5. Priming gravida, 38 weeks in labor, planned for emergency cesarean section due to non-progress of labor. I imagine this particular case long back in 90s. In 1990s, this was the case where cesarean section due to non-progress of labor and delivery of the baby done with classical gymnastics. Still, some people do it. And at that time, I was also doing the same thing. So prior to the something, the same thing, instituting your own hand and asking the assistant to give a fundal pressure. The assistant fails. Ask the anesthetist. The 3-4 people will be pushing the fundus, and you will be delivering it with the hand. And it's really, I find, a really operative gymnastics in the OT for that. And extension after that, there was extension of the uterine on one side involving the uterine, extension of the lower uterine segment on right angle, and it was repaired with it. That is the usual sequence while with hand delivery. Till today, I will say that some of you must have done it, refrain from that, and adopt also how to prevent and how to manage that. An extension of the lower uterine segment right angle, repair with difficulty, traumatic PPH, 2 units of blood given. So what is then I realized? I introspected how to prevent and how to manage for that. This is all because of the difficulty in delivering the head. Difficulty in delivering the presenting part is a real thing. If you have a good delivery, extensor will not be there, bleeding will not be there, complications will not. So the right technique of delivery of the baby is essential for that. So here I learned a lesson, alternative methods. From that day onwards, I switched over to forceps. Now in the forceps again, I have seen some difficulty or many difficulties also, because in forceps, the right cephalic application is difficult. We cannot know which side is a parietal eminence, right, and all that, so that 2 blades can be applied safely for that. Right application cannot be done for that forceps, and if at all it can be done wrong application, there could be pond fracture for that also. Then I switched over to Vectis. Say 1 blade I applied it, that it is just like a same hand, but a hand is little thicker, that is little thinner. But that is a metal and this is softer thing for that. So therefore I was really confused, and I was really discarded the forceps. And then when in late 1990s, when the Celastic vacuum came, I think that Celastic vacuum, after that, before that, that was a Malmstrom metallic vacuum was available. Celastic vacuum, when it came, I think I had interacted with the late Professor Bhaskar Rao at that time. And in one of the AICOGs, he was moving with this newly designed Celastic vacuum. Then we interacted. He showed us how the vacuum is there for vaginal delivery, not for cesarean section for that. So I thought that Celastic vacuum is a much better alternative for that, because there are 2 only things is that you just rule out that is not applied to the face, not applied to the ear pinna. That is the only thing. Otherwise, wherever suture is not essential and all that, you can apply it to rest of the part. And the Chignon formation is not an issue for that also. And cephalohematoma is not an issue for that also, because it's just a few seconds or 1 or 2 minutes the thing for that. And therefore, the vacuum delivery, I have learned from my own mistake of this particular case. Then I switched over to the vacuum. And I routinely from that day onwards, delivery of head by vacuum for long 2.5 decades, 2 decades or so. I'm using this vacuum. If the head is there, at that time, the recommendation that you have an apply either vacuum or forceps in a high head. Now I say that in a high head, mid head, low head, whatever the head may be, if the head is there, I will apply the vacuum in cesarean section for that. And this Celastic vacuum, applying to a normal vacuum suction machine is enough for that. Don't wait to have a Chignon and wait for 8 minutes for that. Immediately within 1 minute, that will be there for that. And that from that day onwards, I propagate this also. And now I'm very happy that there's the extension will be least, and there will be a avoidance of operative gymnastics in the OT for that also. Let me demonstrate this particular case. I think the video is okay. You can, all of you must have been appreciating the video. I hope the technical persons take care of the video for that. This is the lower segment after incision of the peritoneum. We entered into the lower segment, incising the lower segment uterine wall, and giving incision is also very, very tricky. You give an incision, don't give an incision to injure the head. I think that is a very important thing. And I always use a curved seizure and a curved incision on either side so that the uterine is not. Now, after that, this is a celastic vacuum which is being just placed it half to the. Now you find out that this is an index finger. I'm using the index finger to cover and separate it from that. And see, no, even with a no fundal pressure, the baby can be delivered for that. Remember, the application of the vacuum is important, because the vacuum, when you apply it, is a half to the scalp and half to the lower edge of the uterus, curtain of the uterus. So that's why you can see, you can visualize here that I've applied this, and then with the index finger, I just put my index finger and just moved one turn, about 180 degrees to the lower uterine segment, so that the whole cup is applied to the whole of the scalp. And that is the trick for that. And after that, nothing, your purpose is solved for that. And that, remember, I'm applying for that. If there is a low head, the maneuver is that they ask your assistant to push it, disimpact it. And then if you're going for Patwardhan's technique, that is all right. If you're going for the bridge extraction, that is all right. If at all you want to deliver it by head, you push it from below, and then you can apply it by the same vacuum, the celastic vacuum for that. Situation 6, Mrs. G3P2, placenta previa, transverse lie with previous cesarean section at 36 weeks. So placenta previa, transverse lie, previous section, LSS was done. Male baby of 2.4 kg, delivered with difficulty with fracture left femur of the baby, not of the obstetrician, and lateral extension of uterine incision with the broad ligament hematoma, uterine atony, PPH, shock, patient resuscitated and saved. Again, I'm reminded this particular case in way back in 1990s. How to prevent, how to manage. I think prevention is more important. But then I analyzed, I introspect. Preoperative planning. Preoperative plan, no preoperative planning for that. We have not thought of what could be the difficulty. Now, if you have a planning and mental setup, mental makeup, then you can find that this is a case of previous cesarean section, placenta previa, and transverse lie. And preoperative planning must be there. I must know where is the head and where is the foot. Invariably in a transverse lie, obstetricians, they do a cesarean section and introducing your finger and bringing down the hand. Then again reposing it and searching for the leg. Because they do not know, they have not analyzed that which side is the head, which side is the leg. Suppose you have beforehand, we can find that on the left side the foot is there and the right side the head is there. You don't need to go for the left side. I think left side directly you go on the side the foot is there and grasp it so that the hand cannot come out for that. So this is the preoperative planning and anticipate some problem. This is the case of placenta previa. So risk factors identifying post-cesarean pregnancy. Placenta previa, malpresentation, PPH, both atonic as well as traumatic is expected for that. So therefore, this particular case can be better dealt with the senior consultant for that. Experienced people can do it. Professor can come in here. Don't call the professor for decision making in delivery. Decision making is wrong in junior and very senior person. Middle level obstetricians, they make a good decision making whether vaginal delivery or a cesarean section for that. But if you go to the professor, he will go for a cesarean section. If you go to the junior, he will go for a cesarean section for that. So senior consultants are best for tackling the situation, the skill. So what are the preventive surgical steps in this particular case? First, foremost, tackling vessels before incision. Normally when we find that in placenta previa, particularly in anterior placenta previa, there are engorged vessels, which I will show in my video. So engorged vessels, you just don't go and make an incision for that. You tackle vessels before incision. You suture it, give a suture it below in the proximal and distal, and then give an incision in between. That's one. Second, U-shaped incision on uterus, because it's a transverse line, lower segment is not found. And that particular case, many people can give advice that you give a classical incision or the lower segment longitudinal incision. I don't recommend that classical incision for this purpose. And the disadvantage of the lower segment longitudinal chronic incision is that there is invariably there is an extension upwards, and it behaves like a upper segment incision for that. So U-shaped incision is best for that. Even with a lower segment when it is not found, U-shaped incision on uterus is very important. Gentle delivery of the baby, identifying the foot and catching the foot and delivering it, and prophylactic aqualics. You must give it immediately. There is 1 minute or 60 seconds after delivery of the baby. Within the delivery of the baby, within 60 seconds, you must give it. And then apply the 3P. Always, then before that, no muffs. Because don't use muffs on the right. Earlier, we are using muffs on the right and left paracolic gutter. And now the court of law will be there. Forget about muffs for that. More obstruction than muff. Now here, after delivery of the baby, then you don't do a manual removal of the placenta. That will always augment the PPH, and you do a lot of unnecessary procedures for that. Prevent. Don't do manual removal. Give aqualics. Wait for spontaneous separation of the placenta. You can give a traction tension, not with traction for that. And here, 3P's theory I adopt. Pack, press, and pray. And remember that you, after delivery of the baby, you just pack it on the lower segment on the part of the cesarean section, press it, and pray God. And then remember this fourth PC Mahapatra for that. And ultimately, everything will be clear. Placenta will be separated, even with the placenta previa also. The whole lower segment age, which was bleeding with engorged veins and all that, will be absolutely dry for suturing and all that. And active management of third stage, recognize active bleeders. Suppose there is an active bleeders in the angle. Many people use the bleeder along with the muscle and apex in the same suture. Don't use that. Forget about it. So if there is a bleeder, identify the bleeders, take separate suture to arrest the bleeding, then start from the apex for that. You don't include in the same thing for that. Otherwise, it will be really a nuisance value, and it's a really hematoma will grow on. Tackle separately. Optimum hemostatic closure. Hemostasis will be absolutely, don't give a complacency attitude for that. And of course, peripartum monitoring. Situation 7. Mrs. X, Mrs. Y, primi gravida at 39 weeks of gestational age, decided for emergency cesarean section in on. This I am reminded when I was a SOC, surgeon on call. When I got a call in the midnight from my resident that, sir, a case of obstructed labor has come, and caput, lower segment stressed, and fitlot is there, and what shall I do? I told that there is an indication for cesarean, you do it. Then he started, and after half an hour I got again a call from him. So he rang me and told, sir, plenty of liquor, but no baby, please come. So when I rushed into it, I found the problem is identified, and RS was searching for baby inside the urinary bladder. The bladder is cut, and they searching, instead of a baby, he found the urine. And how to deal with this? This is not a very uncommon situation. At times it happens for that, and particularly for obstructed labor, lower segment is distended, stressed, and bladder is edematous, and bladder is raised up, and therefore it is likely that it should be. So preventive steps. What are the preventive steps? Recognize tissues. Identification of the tissues is very important. In this particular case, the edematous bladder has been lifted up. So find safety line, highest point, no haste, no blind procedure. You just see. Don't cut and see. You see and cut. Always the difference between surgeons and gynecologists. Surgeons cut and see. We gynecologists see and cut. That is the difference between surgeon and gynecologist. So no haste, no blind procedure, adequate tissue respect. And this you do it, and preventive aspect. Suppose this particular case, what other is happened? Bladder is injured, bladder you have cut it, and there is no problem. You can repair it. But interventional steps, finish the obstetric part first. First of all, whatever is there left behind, you do the deliver the baby, and then after that, obstetric part suture the uterine incision, Then identify the cut margin of the bladder. The very important is that identifying cut margin of the bladder. Don't have the as and when required, do it and suture it wherever the tissues is there for that. You have to identify the cut margin of the bladder, and watertight closure has to be given in 2 layers, and good post-op drainage, particularly with indwelling catheter, for about a couple of 2 weeks is enough for that. And remember, bladder is the most forgiving organ in the body. Most forgiving organ. You torture the bladder, bladder won't react for that also. It will tolerate for that. And therefore, the good watertight closure is important, and you need not call the urologist for that. And you, gynecologist, can easily suture the bladder for that. But prevention is important for that. First of all, priority will be given to the preventive surgery, then management for that. So learn a lesson for future that don't injure the bladder every time you do a cesarean section for that. Situation 8. Mrs. Y, 32 years, third gravida, para 2, living 2, previous 2 CS, with major degree of placenta previa. There was a third episode of bleeding at 35 weeks. Breach, plan for emergency cesarean section. So now, what are the things, how you go to approach? Now, anticipation. You anticipate. This is a case of previous 2 cesarean section with major degree of placenta previa, which was diagnosed by ultrasound. And it was a third episode of bleeding. You have to do it, but anticipate. And believe me, in placenta previa, while doing an ultrasound, you must find out morbid adhesion for that. So sonographic pointers of morbid adhesion, you must rule out. In all cases, there's been a rule that in previous cesarean section, more so in placenta previa, in all cases, you have to find and identify. It's very easy to identify the cleavage, the morbid adhesion. There are definite criteria with or without the color Doppler, with or without MRI. You can diagnose it beforehand also. And therefore, anticipate that there could be a morbid adhesion of the placenta and previous 2 cesarean section. There could be bleeding, and there could be need of further surgery like hysterectomy. And there is a need of bleeding, therefore arrangement of blood. In none of the cases I've advised for arrangement of blood. Previous cesarean normal cases don't advise for blood also in all cases. Where previously when we were students, all cesarean 1 unit of blood has to be kept ready. No, that's not important. So here arrangement of blood, or the party has to have a standby of donors. Now need for hysterectomy, it has to be counseled for that. And again, I went for that suprapubic incision, extensive adhesion of UB space with engorged veins. And as soon as the UB space was opened, there was a torrential bleeding from the space. Where from the bleeding came, I couldn't find out. Placental tissue was found out in the lower uterine segment. I couldn't find the uterine tissue, but instead of that, placental tissue, which was engulfing the bladder, entering through the placenta, I entered into so the bladder was also involved. So blindly I entered through the placenta, and a preterm male baby of 2 kg delivered by breech and with optimum Obger score. Then I find that the placenta was morbidly adherent to the lower segment and the bladder, and there was an active bleeding from the lower uterine segment. So immediately in this particular case, don't go for stepwise devascularization. Don't go for conservative procedure for that also. That will really be a dangerous procedure, and patient's life is important. And decision for emergency hysterectomy has to be done for that. And therefore, the counseling previously prior to surgery is necessary for that. So total abdomen, and here subtotal has no place. You have to go for total hysterectomy, and that's why there is a difficulty in lower uterine segment. In total hysterectomy in a previous cesarean section with placenta previa particularly. So difficulty in dissection of bladder, excision of the posterior bladder flap along with the placental tissue was done, bladder repaired in 2 layers, hemostasis, good hemostasis is important, and hemostasis maintained, indwelling catheter given, uneventful post-op recovery, indwelling catheter removed after 14 days, and patient and baby was all right for that. And here are the tips and tricks. Anticipate possible problem of counseling. Decision for total hysterectomy, don't delay for decision, not stepwise, no place for compression suture, no place for devascularization for that also. Steady, but first surgery with hemostasis. Not slow and steady, but it is steady and fast. Steady and fast surgery with hemostasis is important.
watertight closure of the bladder, if there is a bladder. Then here there is a bladder engulfing the bladder, the posterior wall, so that cystectomy has to be done, partial cystectomy has to be done, and repair of the bladder, maintaining hemostasis all throughout the procedure. This is very, very important, maintaining hemostasis, because there are veins which ooze out in such a torrential manner that is difficult for that, and it is very important, a good surgical challenge for that. Situation 9, priming gravida, conceived following investigation for primary infertility 5 years at 38 weeks. So sonographic evidence of cervical myoma of 8 cm diameter, again with the transverse line. In myoma, there is a malpresentation, and here there is a malpresentation, priming gravida, transverse line, myoma, cervical myoma. And patient is keenly agreeing for that, because not only for transverse line, but more important that the cervical myoma could be removed at the same time. He is more concerned about the myoma rather than the baby for that also. And invariably, you must have anticipated and expected that. So plan for LACS. So anticipate, what are the anticipation? Difficulty in delivery of the baby because of the transverse lie, and the PPH is more common, and concomitant myomectomy. I have decided that this particular case will definitely need a myomectomy for that also. So concomitant myomectomy, pharyngeal incision was given, lower segment of uterovesical space was stressed, lower segment opened, UV space dissected, transverse incision given, and first intramural myoma of 10 cm enucleated. With the same incision, don't give a separate incision, because it was stretching the lower uterine segment. With the same incision, after removal of the myoma, you just extend the incision deeper, and you can enter into the cavity, and cavity opened. Term male baby of 2.8 kg extracted by breech extraction, placenta low-lying posterior wall. At that time, it was not diagnosed, placenta low-lying posterior wall, and posterior wall was little better in the sense that there is no active bleeding. The bleeding points were there, or engorged veins were not there, if in contrast to the anterior wall. Anterior wall, there is a engorged veins is there, but posterior wall, what happened? After delivery of the baby and the afterbirths, it was not a morbidization. After the delivery of the afterbirths, I found that there was a oozing from the placental bed from the posterior wall. So here the technique is that you apply a hemostatic suture over the placental bed where there was a bleeding, and that is really a good mechanism, good tips for surgical tips for control of the bleeding for that. And don't leave it even with the pressure also. If it doesn't it is not controlled, you apply hemostatic suture. But one important tricks I will give you and share with you, that many people give a stitch superficially to the decidua. That will again aggravate more of bleeding. So take a deeper bite, including the muscle and the decidua, and a figure of 8 you give it, and just stitch it, and stitch with catgut. Catgut is a better suture than the vicryl, because vicryl may tear off with that. So catgut is much better. I found my observation in that particular hemostatic suture. Posterior wall, bleeding points, take a deeper bite, figure of 8 with catgut, and it's closed. Then the uterus is closed in the same incision. The difficulty here will be a thicker myometrium. A redundant myometrium, you can excise it, and you can stitch the bed of the myoma along with the uterus posterior wall, make it a one flap for that. You may be able to require additional suture for dead space closure, but in the same line of incision, you can close it. And maybe that you can have an additional 1 or 2 stitches for hemostatic stitches for that. But this gives an uneventful post-op recovery for that. So the tips and tricks: anticipation, difficult delivery, myomectomy, controlling PPH is absolutely important. People say earlier the indication was that we always teach students that the cesarean myomectomy only in 2 cases. Only when the myoma is occupying the lower uterine segment over the line of incision, and second, pedunculated subserous myoma. But don't go for myomectomy in an intramural myoma for that. So that was the recommendation for that, because it will be a lot of bleeding for that and controlling PPH. Now, yesterday's contraindications are today's indication. I am now proposing that all cases, my practice is doing a cesarean myomectomy in all cases wherever the myoma needs to be operated. Suppose the myoma needs to be operable, the size is such that it needs to be operable, it is removed, I will do in the same sitting, even if it is a case of intramural myoma for that. So that will really elevate, and there are a lot of advantages that you just avoid one other second surgery for that also. And therefore, this is the situation where cesarean myoma. This is a case where it is inevitable. You have to give an incision in the lower uterine segment. But otherwise, if there is an intramural myoma also, after the delivery of the baby, you can do a cesarean myomectomy. And I always say, advise, I'm always in favor of cesarean myomectomy, and this is a very favorite surgery of mine for that. And just see it. This is another case, an intramural myoma. Just see the video. After delivery of the baby, I find that the myoma is in the posterior wall, and there's a big intramural myoma of about 15 centimeter, 15 centimeter diameter. So I don't want to give a separate incision on the posterior wall normally, and I devised this as an intracavitary myomectomy. Through the cavity, before stitching the cavity, through the cavity you find out, and with the just a retractor, if there is an anterior myoma, you can retract it and place an incision over in the endometrium, in the decidua, and through the, when you find the myoma in the space, then the Bonnie's myoma screw, you apply it and give a traction, and so that you can deliver it if you go to the proper cleavage path. The advantage of this is that intracavitary myomectomy, it is possible. It is not possible in a subserous myoma, but intramural myoma, it is possible wherever it is, either in the anterior wall or a posterior wall. After delivery of the baby, you just identify it and then retract it and just deliver the myoma. And the advantage is that if you give an outside incision, 2 incisions are there, and there is a lot of adhesions, pain, bleeding, everything will be there. And here, if you just give it, the whole uterus will contract and the dead space will be minimum. So you can again close that dead space in separate occasions. If there is a big myoma like this, we have a different, we have a long dead space where it is first before stitching the peritoneum, before stitching, closing the uterine muscle, you just oppose the dead space. This is the layer where you find the excised portion is there. Then you can find out that this is the cleavage. This is the bed of the myoma, which you can clearly show, and you go for a continuous suture, an hemostatic suture, or interrupted suture, and with hemostasis. See, this sort of myoma, when I would have gone for again a separate incision, there will be torrential bleeding, and the length of the incision is much more than what is there inside. So intracavitary myomectomy is a very, very important. All of you try that, and then you will say that it's a good procedure for that also. Do a seizure, but don't attempt myomectomy unnecessarily, because suppose a settling myoma, 2 centimeter, 3 centimeter, 4 centimeter myoma, don't do a hysterectomy, don't do a myomectomy in that. The cases where it needs a surgery, a bigger myoma, more than 5 centimeter, then it is justified for that. Otherwise, in pregnancy also the size increases. So you can stretch it up to more also, 8 centimeter and beyond. You can have that, and don't remove these seedling myomas or a small myoma. And this I have learned that it takes 5 years to learn to do the surgery, but it takes 25 years to learn not to do the surgery for that. And that's a learning for me, that you have to know where surgery should not do it. And this is a case where myomectomy can be done. After that, you see the uterine muscle is being closed. The first layer is being closed with, and always remember, last time also I told that whether locking suture or unlocking is immaterial, whether you take a full length or decidua separate is immaterial, but a good hemostatic suture is necessary, and suture material should not be more than 10. The thinner the suture material is better. People use more number one. Forget about it. Use 10 vehicle for that. And second layer, we go again with the Lambert suture, and this is the peritoneum which I close it. And now I find that the vessel peritoneum is closed, and then the parietal peritoneum is closed, and then the abdomen is closed in layers. Because many people do not close the peritoneum also. It's all right. I don't say anything about the Misgab Ladakh and all that Joel Cohen incision, but I have done that in 50 cases. My personal experience, I have not been very happy with this. I didn't find any advantage over it. so that my own classical method, whatever I'm not a healer. I will cut it. I'm a dissector. I'm an operator. I'm a surgeon. I will cut layer by layer. Whichever layer I will cut it, I will just approach it. God is there to heal it for that. So why I leave it for that? And even if I will recommend that, one case I remember that the peritoneum, I was being called after 8 hours. Some surgeon, MRCG fellow, did the cesarean, and he was absent. After doing a cesarean, he left. Then the patient was in shock, and after 6 hours I was called, and I find that the patient was in shock. There is a hemoperitoneum, uterus was distended. Then immediately I told that you bring the blood and I will open it, otherwise I will not able to save the life. Believe me, when I opened, I thought that it must be from the uterine incision, the bleeding is there. Believe me, the uterine layer was absolutely clean. There was no hemal bleeding, but the visceral peritoneum, there was just spotting vessels in the edge that lead to a conservation. So that from that day onwards, I always tell, if you are leaving the peritoneum, see for hemostasis. Leaving peritoneum, I agreed, you can leave it, but before that, good hemostasis has to be maintained for that. In previous 2-3 cesarean section, you cannot get a peritoneum also, you can leave it for that, but I will insist on good hemostasis for that. Situation 10, G3, A2 at 36 weeks, previous 3 episodes of bleeding PV, sonographic evidence of low-lying placenta with breech presentation, and plan for LSCS. Surgical approach, see the video. Now, after the delivery of the baby, before the delivery of the baby, I find torrential bleeding in the interior because the placenta was low-lying, placenta previa, anterior. There was a torrential bleeding for that. And layer by, when I cut it, the uterus bleeds so much. Now I find the 2 layers I cut with the Alice forceps, one on the top and one on the bottom, and half. Then I could find that this whole of the placenta is there. Now the whole of the placenta I could find out, and I tried to find out and negotiate where is the membrane which could be there or not. And if there is a membrane which is there, I would have ruptured the membrane and brought that. But I couldn't find out. I went through the placenta, cut through the placenta, and then I could enter into the cavity and the amniotic cavity. Then with the delivery of the baby by breech presentation, by footling, you deliver the baby. I delivered it, and then you see. So there are 2 methods. If there is a placenta previa anterior, all the precautions as I have already told about the hemostasis and all that, you do it. And then second is that you delivery of the presenting part, delivery of the baby has to be done either by searing the placenta and getting the placenta when there is a partly up and partly down. You can find out and cleavage and find out a membrane and puncture it and then do it. Otherwise, you can directly go through the placenta, and like this particular case. And you can find the placenta interior, and clearly you can find that about 1/4 of the placenta is below the lower uterine segment, and that is a simple adhesion. It's not a morbid adhesion, and I allowed for a spontaneous expulsion after ecbolics. Good ecbolics has to be given within 60 seconds, and that is nothing but oxytocin. I don't recommend for prostaglandins for immediate. This for therapeutic, but not for preventive purpose. Oxytocin 10 units IM and 10 units drip is enough, even for placenta previa, even for the twin pregnancy where expected bleeding is there, even for hydramnios where expected bleeding is there. Now this is a simple adhesion, and with the finger it can be separated, and whole of the placenta can be delivered for that. And then you go for hemostasis. If there is a bleeding, you can suture it the bed, and usually in anterior placenta the suturing of bed is not necessary. The posterior there is usually bleeding, then you suture it and close it for that. Now the tips and tricks are there. Hemostatic suture, proximal and distal in anterior low-lying placenta. This is important, I have already told. Deliver the baby through the placental tissue or finding cleavage and entering into membranes. And timely ecbolics has to be given. Hemostatic suture in the placental bed, and that I have already enumerated. You take a deeper bite for that also. Situation 11. Mrs. Jed primigravida, elective CS was done for breech, torn breech with PIH. Uneventful recovery, surgery. Surgery was absolutely uneventful. Transferred to the ward, and after 4 hours, reported to a peripheral circulatory failure with respiratory distress pulse rate 160 per minute, BP not recordable, sweating. Now, what is the workup? There is not a problem during intraoperative period. And what is the workup? Think of possible causes. Is it anesthesia related? Is it drug related? Is it surgery related? And this is the cause which first think of it. Anesthesia related, at times the long-acting regional anesthesia sensor can have a effect, long-acting effect. So think of this. Drug related anaphylaxis reaction, either due to analgesics or due to antibiotics or due to any other drugs, drug related, think of it. And most important, as a surgeon, think of surgery related. And in surgery related, bleeding, internal bleeding, you think about it. External bleeding, you can find out. You think about internal bleeding and exclude that there is no internal bleeding by clinical or by sonography or whatever means. You just exclude intraperitoneal bleeding for that also. And then think about non-obstetric cause like embolism, like sepsis, and undiagnosed entity. It is a complacent attitude of the obstetrician to level it as a case of amniotic fluid embolism in this type of cases. I am really skeptical about diagnosis of embolism, amniotic fluid embolism. This is all right for legal purpose, but for scientific purpose, it is $1 million question for that also. You have to prove amniotic fluid embolism. Whenever you don't find any cause, you level it as a case of embolism for that. Even some cases, if you think of embolism from the first time, from the onset, you ignore bleeding. There could be bleeding and you could have saved the patient for that also. And early intervention could have been done. Sepsis, very rarely within 4 hours, sepsis could be there. And this is an elective cesarean section. Usually sepsis in gynecology, particularly early sepsis within hours is only seen in urological case. But in other cases, it will take a time. And maybe that in pre-existing infections, in a case of chorioamnionitis, it could be manifested within hours, but not within so early period. In that particular case, has to be diagnosed. Now, what are the tips and tricks? Such things do happen. Identify the cause and appropriate intervention. Here is the need for obstetric ICU and a multidisciplinary approach for that. A multidisciplinary approach, need for obstetric ICU, and correct diagnosis and supportive measures has to be instituted to save the life of the patient. Situation 12. Mrs. D, primigravida, underwent LSAS 3 months ago and persistent discharge from the wound and therefore from the various parts of the wound there was debridement and exploration done once and again recurrence, and the surgeon wanted to have a second time exploration with multiple indurated area above the scar in the abdomen. And the first surgeon who has done an exploration wanted to do again an exploration for that. So she came to me. I find that the sonography for sinus tracts, and there was a collection with special reference to anterior parietal wall. There is a parietal wall. And here in this type of cases, remember, when there is a repeated recurrence of multiple sinuses following cesarean, and it is not immediately, many cases, normally what we find is surgical wound dehiscence. Wound dehiscence is different, either superficial wound dehiscence or a deep wound dehiscence or a septicemia. There is another aspect for that also. If there is a wound dehiscence, you can do a debridement and secondary suture for that also. But it has done 3 months before, and then it continued one after another. After exploration also, you find that another thing will be there. And these are the cases. You just give giving a tip and trick for that. What could be the cause? Atypical mycobacteria could be one, and foreign body reaction to suture could be another thing for that. But again, foreign body reaction to suture, we are giving a Vicryl, and 90 days, 3 months could be enough. Beyond 3 months, it is not there. Maybe that in early part that could be manifested from the beginning for that. And that is in majority of the cases will respond to AKT for 3 months. Remember, if you find such cases, you first give AKT for 3 months, entity over Clarity-Cox treatment, empirically, therapeutic trial for 3 months. Believe me, after 1 month, after 15 days, you see the result, and complete wound healing will be there after 1 month. And you continue for 3 months and remain assured. Majority of the cases, I have a couple of cases are like this, about 20-30 cases I remember that has been completely lived with AKT for 3 months. Now there is some exception for that. I find 2 cases of mine, like same cases, but it was not a complete the sinuses. Sinuses are healed, but it was an abscess which is just above the scar, and it is a frankly an abscess on aspiration. It is found with that, and this is one case P2 both LSCS LCB 5 months ago with recurrent parietal abscess above the scar. Same thing, and it has been a drainage about couple of times, twice it has been done by a surgeon. They drain it and just explore it and drain it, put the incision and drainage, and again it has recovered. And then when he came to me, again I have the same principle of giving an anticox. An anticox for 2 months I given. After 1 month there is no response. After 2 months also there is no response. Patient was having terrible pain, swelling, and all that. And therefore I planned for exploration for that. And what is the surgical approach? See, this is the case. This is the Cesarean scar, and above it there is a definite bulge, and on ultrasound I find about 8 centimeter anechoic area in the parietal wall for that. So here I had planned it to have a wide excision for that. Not simple drainage of the point, drainage of the abscess for that. And I decided that I will do a wide excision of the granulation tissue along with the cavity of the pus. Cavity of the pus. Now I find total. Can you see that there is a pus which is thick pus which is coming, and there is a big cavity I found out for that. A big cavity was found out, and there the I had not left it. Suppose I had done a drainage, again should have presented like this in previous cases because it underwent like this. Now you can find the cavity, clear cut cavity can be found, and the wall of the pus pocket can be found for that. So I do a healthy margin and wide margin on wide excision of this particular cavity of the pus purulent, and all around I did it, and went inside and find out where up to what time it is there, up till whether it is above the rectus sheath or involved in rectus sheath or gone to the muscle. You can see clearly find out the whole of the sheath. The one fragment of granulation tissue is removed. Then this is the real sheath. This is the cyst and the abscess cavity which is there, and all around wide excision with the rectus sheath. I just went it, and I find that it's completely fixed to the rectus sheath, and it has gone right up to the muscle. Rectus sheath is not separable for that, and I cannot come out of that unless I do a wide excision for that. You can see that this is the whole of the cavity, and I found out that this cavity, and again another trick is that you find some of the sinus tract running from this cavity or not. That also you rule out, and if you find that granulation tissue, you have to excise it completely. Otherwise, there will be again a recurrence for that. And you see that this is a very challenging surgery, and thinking that again the same problem with a lot of challenges, I have done that, and believe me, it could be done. And I find, unfortunately, this particular case, I had to go and excise the rectus sheath also, and some of the portion which is directly fixed, the cavity cyst is directly fixed to the cavity, the rectus sheath, so that from the muscle onwards we just dissected. The only trick is that you go in a wide dissection and dissect it and find it out where is the limit of that and where it is attached to that. And this is all around in all directions, you just find out. And with the hemostasis, I think with the cautery, with the electrosurgical device, with the current unipolar current and cutting current, you just excise, and then you can go and see. The trick is that you cannot, because this is really a challenging situation. They have been operated twice, so this is the third time. I'm apprehending this that in the say if that same thing will happen, what will be my fate for that? So, and this is the second case in my life which I have shared. This is not responding to AKT. Could it be? Then I thought of some foreign body reaction and formation of this abscess for that, which has not responded to anti-tubercular regimen. And you can see clearly that it's not coming out of the rectus sheath. So it is attached to the rectus sheath all around in the healthy margin. Can you see that I have incised the rectus sheath all around? And then I can find that this is whole of the tissue, granulation tissue along with the cavity with the containing the pus. I can remove this completely so that the next time there cannot be a recurrence for that also. So this is, if you're going for a surgical challenge, I think do a good complete surgery. Don't do an incomplete surgery for that also. And don't do just for drainage and all that, post drainage, and then again it will recur for that. And very gently, and you go step by step all around, and then the whole tissue can be dissected and can be removed for that also. Now you can find that the whole of the rectus sheath is involved, and it is fixed to the rectus sheath, and unless we cut it with the whole of the rectus sheath, the part of the dead tissue, part of the tissue with the pus cavity will be remaining. Then you can see here that how it has been dissected, and this is the last part. This is the last part. You can see the muscle below, and after incising the rectus sheath, the muscle is seen. It is fixed to the almost the sheath. But unfortunately, I'll also see whether it has gone deep into the muscle or not, and the rest part of the dissection will reveal me whether it has gone into the muscle or it is outside the muscle for that. It is, of course, I found that it is sitting on the muscle, and this is the part where you can completely remove it. Can you see that it's completely removed? And when I inspected, the whole of the pus cavity can be found out for that, along with the dead tissues. Then this is the muscle, rectus muscle and the rectus sheath, which is being opposed and closed in either with a interrupted suture or with a continuous suture, aided with interrupted suture with the drain. I think drain is a must, and this is a suction drain which has to be given. And I have put a suction drain, Romovac drain below the sheath and above, one below the sheath and above the sheath in the subcutaneous plane, so that the whole thing can be really sutured for that. And that is the situation. And this is a very rare case which I find, and only 2 cases in my life, and both are doing very well. And fortunately, it's a good luck for me that the patient was very happy, because they suffered for about a couple of months following a cesarean section. And this is the case where I want to share my experience with all of you for that. And this, you can do it yourself, and it's not a big job. And but the only thing is that the trick is that wide margin, with a healthy margin, you take it and then close it with the vehicle. I'm closing it with the vehicle. I don't use the proline suture for that, and immediately longitudinal continuous locking suture, and again few interrupted suture for the additional strength for that, and then the skin has to be closed for that. Again, 2 drains are given, one below the rectus sheath, another above the muscle, and another in front of the rectus sheath in the subcutaneous plane for that also. Thank you. This completes so the tips and tricks here. Medical management is the priority. Usually responds to anticox. I always say that anticox you give it. Comorbid conditions to be excluded, risk cases, surgical challenge, wide excision with defining the healthy tissue margin, exploring the sinus tracts, suction drainage, and antibiotics for that also. Now the last situation, 14, I'll finish it. Mrs. B, para 2, both LSCS, LCB 1 year ago, acute pain and swelling in the left angle of the scar during menses. Classically, from the history, you diagnose that there is a scar endometriosis. Sonography corroborating with the clinical findings, and these are remote complications of the scar endometriosis of cesarean section. Particularly earlier, we were seeing in hysterotomy. Now we are the possible prevention hysterotomy, and particularly seen in preterm delivery and cesarean section. I think this possible prevention, but there is no definite cause which is attributable, but there could be some of the theories which some of the measures, preventive measures you can take it. Separate muffs for parietal wall. Don't use the same muffs for the uterus and parietal wall. Parietal wall, take a separate muff, because this is the implantation type. Decidua might come here. Separate muffs, you use it for that. Avoid extravasation of the uterus. Extravasation, don't use extravasation of the uterus inside your suture. And using different suture for closure of the rectus sheath. Many people, what they do, they close the uterine incision with the vicryl, and with the same long vicryl, with the same suture, they close the rectus sheath. Don't do it, because the sheath may contaminate, the suture may contaminate some of the endometrium, and therefore a different sheath has to be used, different suture has to be used for that. And this is a case, just see, watch it. This is a scar endometriosis. Again, the same thing. wide excision. There is no medical management of scar endometriosis. And remember that scar endometriosis, you can do it is a parietal wall. It is not extended below. And remember that you have done an already ultrasound to find out, to locate that is a parietal swelling for that. The only thing is that you have to have a wide excision for that. And if you do not have a wide excision, again, the chances of recurrence will be there. Like that previous case also, we did the same thing. We dissected all around for that. And therefore, after dissection of all around, you see, we do not know how depth it has gone, whether it is up to the rectus sheath or involve the muscle, we do not know. So go step by step for that. And a big, I think, if you go all around like the previous case, we go in a healthy rectus sheath, we can find out after this subcutaneous plane. But circumferentially, all around, you can encircle the mass and go all around and find out the real cleavage line. And then you can say that, yes, this is. Okay, you can clearly appreciate the rectus sheath now. I am giving that this is the hemostasis, the active bleeder. Just hemostasis has to be given for that, utmost importance. And remember that this is a rectus sheath. You just go with this cutting current and with the unipolar, and all around you just have a wide margin and healthy margin for that. And this is the trick of scar endometriosis, because we do not have any medical management for that. They don't respond to it, and we do not know the inside, wherever the depth is there, up to what extent we can go it. After dissection, we can find the depth of involvement and how deep it has gone, whether deep into the rectus sheath or inside the subcutaneous tissue above the rectus sheath, or it has gone deep inside. At times we find the muscle is also getting involved for that. But here I find that I've dissected all around the rectus sheath, and then we can find out that where is the plane of cleavage, and then complete excision. The motto is that you have to do a complete excision. The total, if some tissues is left behind, again that will grow, and again there will be recurrence for that. One of the major difficulty of the scar endometriosis surgery is that if you are not doing a good surgery, again there is a chance of recurrence for that. So we want a preventive surgery and a good piece of complete surgery for that. Now you can find out that it is in the above the muscle. Above the muscle we can find out, and there's a lot of bleeding, and we coagulate with that. The muscle you can find out, and here the branching, the feeding vessels are there, and you take an optimum precaution for hemostasis for that. And this is the end, I think, the last piece, and you can find that we can clearly come out, sell out the whole of the scar tissue, the endometriotic tissue above that, and that is the end of the procedure. You can find the rectus muscle below, and this is the rectus sheath, and if you remove that and close the rectus sheath, it has not gone to the rectus muscle. Above the rectus muscle, we just incise it like the last case, and there was an abscess, but this is a scar endometriosis for that. And that completes the procedure for scar endometriosis. So this is a remote complications where we do not know the cause, but this could be possible cause for that. And this is really gives a cyclic pain, and the history is very, very diagnostic. From the history, we can know that this is a scar endometriosis. And you can see in section, even cut section, you can find the endometriotic tissue and send it for histopathological examination and confirm this, that this is a scar endometriosis for that. So this is a clear-cut case of scar endometriosis where the surgery is the main treatment for that. So my dear viewers, learn from others' mistake, again gain from your mistake. That should be the first philosophy for that. And introspect, critically analyze, and update all the time for that. Always try to improve so that your skill will improve. And this is a skill transfer for which I have my share of doing a mistakes. I am sharing with you so that you will not do the same mistake. But ultimately, believe me, the old proverb which from my childhood I have learned, that practice makes a man perfect. My father was telling, practice makes a man perfect. When I grew up and exposed to different problems, then I say that practice doesn't make a man perfect. It's wrong. It is a perfect practice makes a man perfect. If you do a wrong practice and going on that practice, you are a wrong practice and you are expert in that wrong practice for that. And perfect, imperfect in that particular way. So perfect practice, learn from good techniques, good surgeons, and then you have a perfect practice, then it makes a man perfect for that. So the last words continue to be one of the best profession gynecologist. I'm proud of being a obstetrician and gynecologist because it's the best profession in all centuries, past, present, and future. Amidst pains, pleasures are there with us. We are that category of the faculty where it is a painful pleasure or pleasurable pain, whichever way you interpret. But pains as well as pleasures are there with us. We are more ethical, more moral, more human than any other faculty, any other in the faculty of medicine, branch of medicine. We have amalgamation of head, heart, and hand. Many people have an amalgamation of head and hand. We have an amalgamation of obstetricians. I'm proud that we have a heart in it because the emotion is there with us. Mother and child are there with us. And after lastly, it's an amalgamation of art, science, and commerce. We are art and science of commerce are amalgamated. Beautifully, I must give a credit to the person who has coined the term obstetrics and gynecology, tricks of obstetrics and logy of gynecology, art of obstetrics and science of gynecology. Both we cover it, and that's why commerce and commerce are following us, so that other people, surgeons, physicians, and other faculties are envious on us that commerce is following you and prestige is following you, and we are the real winners for that. Thank you very much, ladies and gentlemen, my dear viewers. Thank you very much, Dr. Dewan, Alad, PK Guha, and all the team from Juventus, that I could share my mistakes to all of you. And that is the thing which, as a teacher, I'm really fond of this particular program. Again, my sincere apology for the last second episode that I couldn't do it, so that the third episode would be there. If you like it, then we'll continue in the next episode after 15 days. Every 15 days, we are doing a separate thing. Again, on different subjects on surgical demonstration and then solving clinical dilemmas for that. Thank you, Bhupesh, for giving me this opportunity. And if there is any questions and the chat box and all that, I am free to, if time is there, I'm free to give an opinion and interaction, because this is an interactive session. Thank you.
Sir, let me just tell you, it was another one of the best spellbound session which you have conducted. And it's so impressive, like, you're flawless, and, you have shared so much of wealth of information. I think everybody attending it must have gained a lot from today. And it's very, very practical experiences. So, sir, as we were discussing, there are so many queries which are pouring in continuously. And most of the queries, like, they were pouring in. See, simultaneously, you were speaking about that answer also. So, so many were answering and thanking you while they were putting the queries,
Oh, thank you.
It was a kind of good session, sir. Very interesting.
But if there are queries also, you can let me know so that I can answer.
Yes, sir. So there are a few queries which I would like to, sir, put across to you. So, sir, I go one by one with those queries.
Yeah.
There is a query which is saying, this is from Dr. Niladri Sen from Durgapur. Like, as the patient was operated twice before, so which one will be preferable, through separate incision or through the same or previous incision in your septic surgery?
That abscess, recurrent abscess.
Yeah.
Well, if it is close to the incision, you go through the same incision. If it is away from that incision, this particular case is just about 3 centimeters away from that incision. So I have to give a separate incision on that particular side, because I have to have a wide exposure for that.
Right.
Otherwise, if it is below the scar, you give a separate, same on the 3 incision. Say, for example, in scar endometriosis, I didn't give a separate incision. On the side of the scar, part of the scar, whole scar I didn't excise because it's on the one of the angle. And that angle on the same incision side, I excised it for that.
Okay, great. Sir, there is a query from Dr. Pramila Malik. She says that whether there was any pus culture required or done for
I have done pus culture, I had done a post culture, and accordingly the sensitivity also I gave a post-operative antibiotic, changing it after 48 hours. But that is supplemented thing for that.
Right.
And earlier in the previous occasions also they have done a post culture, and according to the sensitivity they have also given the antibiotic.
Right.
After drainage, the surgeon has drained it and given post culture and given antibiotic, appropriate antibiotic, but still the recurrence is there.
Right. Actually, sir, she is in the continuation of her, queries. She is saying that most of the time these atypical bacteria, they don't react, or they don't are sensitive to ATT. So that's why she was saying probably some other medications, if we can get.
Yeah.
Okay. Right, sir. So then another query is coming from Sivan from Dr. Ranjita Srivastava. She's asking about what to do in case of subserous myoma.
Yeah. Now, if it is a subserous myoma, you cannot do a intracavitary. It is not absolutely not possible. It is not recommended also, because intracavitary gives a lot of advantage for that. You see, hysteroscopic myomectomy versus laparoscopic myomectomy. Hysteroscopic myomectomy is much more better for the uterus, for fertility for the patient, than the laparoscopic myomectomy. Same thing if you do with that, but if it's a subserous fibroid, you don't go through the cavity and weaken this muscle for that. And particularly subserous fibroid, you can give a separate incision. There is no alternative for that. And if it is a pedunculate fibroid, it's well and good for that. But if it's not a pedunculate but big subserous fibroid, you have to give a separate incision for that. Okay. Because we want the length of the thickness of the muscle to preserve more distally.
Right, sir. Great. Sir, there is a query from Dhaka. This is Dr. Irin Parveen Alam. And the query is that how to overcome difficulties during LSCS in an obese patient.
Thank you very much. At the outset, I must think that you are viewing from Dhaka. I think this is I think an honor for me, and I must compliment that you are so much interested in this teaching session. For that, from Dhaka, you are observing that. That's the first. Now, obese patient, it is number one is that the surgical problem will be there. Surgical problem will be there. Then some medical problem, anesthesia problem, and post-operative problem. I think the anesthesia problem can be best tackled with the anesthetist. And I know that it is difficult to give anesthesia, particularly regional anesthesia, which is a preferred thing in this particularly obese patient. But I will just insist that go for the regional anesthesia than general. General will be more problematic and more risky to the patient, number one. And second is about the surgical problem. In the surgical problem, the main difficulty is an exposure, where I will suggest you need a second assistant or third assistant to drag only the abdominal parietes for that also. That is another thing. And go little slow by slow, and don't be hasty in the procedure for that. And otherwise, in the operative techniques, there is no problem, excepting you must be very careful about putting a subcutaneous drain. I think that's a very important thing. The drain has to be put for that. And in the retractors, good exposure is necessary by the assistant for that. That if you need a good assistant, then things will be okay for that. The next is that the early ambulation is necessary. The risk of the DVT, I think the DVT and embolism is there. My policy, all cases whose weight is more than 90 kg, I will give a prophylactic low molecular weight heparin perioperatively. All cases. If there is a history of DVT, we give it. There is no doubt about it. But even if there is no history of DVT, for prevention of that, just a day after surgery, I give 60 to 80 units of low molecular weight heparin daily for 3-4 days. Maximum for 72 hours if you give it, that will give a preventive thing for DVT. That I will insist. That all cases, obese patients, more than 90 kg, just give 3 days low molecular weight heparin for prevention of thromboembolism for that. DVT, early ambulation is another for that. Of course, with the routine antibiotics for that.
And what kind of dose would you advocate for that?
Usually 60 to 80 units per day. Say
Okay.
40 units twice daily will be enough for that.
Right.
Or 60 units you can give once or twice, you can enough for that. But 80 units is enough for that.
Enough. Okay. Right. So there's another query from Raigar from Dr. Jyotsna Agarwal.
Yes,
And
Josna.
yeah, she's saying that what is the lower uterine segment fibroid LSCS? Like, you know, what to do in the lower uterine segment
But
fibroid.
if it is a lower segment fibroid, you find out whether it's an anterior or a posterior. If it is an anterior, you give an incision on the lower segment on the muscle and do the myomectomy first. And with the same incision, you enter the uterine cavity and deliver the baby. That's very clear. That in this particular case, I have shown you. But if there is a posterior fibroid, lower segment posterior fibroid, you deliver the baby, and it's easy to do an intracavitary myomectomy through the posterior wall. There is not a problem for that.
Okay, sir. Another query is coming from Warangal, Dr. Neeraja. She's asking, where can we get the previous session slides? So now that's a...
Oh, previous session slide, I think whole of the, I have first in the, my way of doing a cesarean section technique I have given in the first episode. Second episode, right from the anesthesia till the complications, what could be there, everything is laid down with that. And I think the one we are discussing that, and you are the best person to provide them this slide for that also. And certainly I will honestly request you that if the people, if my fellows want it for an educational purpose, you can hand over it personally to them.
Oh, definitely, sir. It will be our pleasure. Sure, sir. We'll do that.
Take note of that.
Sure.
Dr. Sahab, we have just sent an email ID on which you can, announce that if you request on this email ID, adityabardoli@juventus.com, they would get all the previous links.
Just send it to everybody. Just send it to everybody. Whoever wants it, we give it. And after the whole surgical session for 6 months or 1 year, we'll compile it and form a different, I think, pen drive. And those who want it, we'll give it for them. That will be good. That will be good.
Sir, there is a query from New Delhi. This is Dr. Anita Agrawal. One second. I think the queries are coming so fast that it goes down, like, you know. Okay, she's saying, like, should we do myomectomy first in case of lower segment myoma?
Yeah, otherwise you cannot deliver it. If a lower segment myoma, in anterior myoma, you have to do it. If the lower segment myoma is there in the lower segment anteriorly, you cannot approach the lower segment cesarean section. You have to deliver it myoma first, myomectomy, then deliver the baby. So the first baby, you show the mother that this is your first baby, the myoma. Second baby, the real baby I am giving you. But the posterior myoma, you deliver the baby first and then do the myomectomy in the subsequent.
Sure. And sir, she's also asking about, one second, give me a moment, sir. It just runs away, like, you know, so many, sir, flow of, sir, there are a lot of queries. So how would you like to handle it? Like 100+ queries are there.
Oh, on answer, which is on answer, you just hand it over. I will see you give it.
Yes.
And you note down the number, email address and all that. If there is a time, we can continue this.
Yeah, we can do a few.
The rest of the cases we'll deal with that.
Yeah.
Or you keep it subsequently, we'll have a query session and all that in the episode.
Sure, sir, sure. So from Chennai, Dr. Vijaya Lakshmi Sheshadri is asking, like, you know, there are double plus adhesions, previous LSCS,
Yes.
repeat LSCS. If we can make way in and out, we can leave off adhesion, isn't it?
Pardon?
She's saying we can leave the adhesions over there, or should we,
No. I think leaving the adhesion is not a issue, or dissecting the adhesion is not an issue. Now, I think the completing the procedure, and you can leave the adhesion. You don't try to do an adhesiolysis in the same sitting. You can invite more a problem. I think leaving is more favorable than doing an undue dissection for that also. And I fully agree.
So this is again from her only, like, midline vertical incision with delivery of baby by classical LSCS without touching placenta, followed by total hysterectomy with placenta in situ cystectomy required if bladder is involved. So,
Yeah.
like
I think that is also one some of the reported journals, they say that here is one indication for elective cesarean section, and then after that, where you have decided that this particular case we have to do a total hysterectomy, and with that, but unless we dissect it, we couldn't know that it's involved the bladder. Suppose we would have diagnosed that it's by ultrasound, we would have diagnosed that it's involved bladder, then this plan is already good. But if you are not known it earlier, after dissection, we could find that it has engulfed the whole of the bladder for that also. But if it is diagnosed previously, I think this should be a good option. You just counsel the patient that I'm going for cesarean hysterectomy, and in that case, you do a classical cesarean section, deliver the baby, then going. By that, the advantage is that undue blood loss will not be there. You can get a good cleavage for that in the lateral part, not in the central part, but at least in the lateral part, you can bet the hysterectomy would be little easier than the other cases.
Sir, an important query is like, how do we safeguard the ureters in cervical myomectomy during LSCS?
Now, when there is a cervical myoma, the myoma has already displaced the ureter laterally. So the myoma has done the job. So you need not be worried about myomectomy, the ureter incision. Now, the only thing is that in a broad ligament myoma, there is a problem of ureteric involvement for that. But otherwise, there is not a problem. But problem arises in cesarean of ureteric involvement in a case where the lower segment is not well formed. It is a tubular lower segment where laterally, if you extend it, then there is an injury to the ureter, the bladder, the uterine artery, and on attempt and tackling the uterine artery, you are liable to injure the ureter or tie the ureter in the lateral angle for that. So therefore, the recommendation is that is a U-shaped incision. So therefore, I will always recommend that instead of a longitudinal, midline, longitudinal or chronic incision, you give a U-shaped incision and you can be safeguarded for that.
Sure. Sir, another query is regarding the use of vasopressin. So can we give vasopressin for myomectomy in LSCS?
You can give. There is not a problem for that. You can give a vasopressin for myomectomy, but this I will never recommend for intracavitary myomectomy.
Okay.
Because intracavitary is not necessary. But if you are going for a subserous myoma, not pedunculated, and it's a big myoma, you can do it after you have delivered the baby and all that. We do not know what will happen and all that.
So there's a query from Chennai again. Can the cord loops come out earlier before the fetus delivery in LSCS? We know the time lag is not much.
Yeah, this is a usual sequence of events where you want to deliver it and a cord comes. And this is very common in malpresentation. And every time you repose the cord, again it will come out for that. And what is the time lag? If you don't consider the time lag as minutes, consider in your brain as seconds. If you consider minutes, 1 minute, you'll be more hasty and doing more problem for that also. Go slow, there is nothing a problem for that. Even consider that in a breech presentation. You have to go that after the umbilicus is delivered, you remind of your old teaching and training that from the time of the cord till delivery of the bed, you need a lot of time. In say 3, if you consider 1 minute also, you'll be hasty for that. If you consider 60 seconds, then you'll not be hasty. There's not a problem if you go for more than within 3 minutes, you can deliver it also.
So now moving to the west part of the India, queries coming from Jodhpur, Dr. Indira Bhati.
Yeah. He's a big professor. He's a big professor in HOD.
Yeah.
Yes.
So she's saying, so when you apply Ventus at C-section, is there no need to apply it over flexion point?
No, you cannot identify flexion point because flexion point is a theoretical thing. And we teachers teach the flexion point and without knowing which is the flexion point. Even if I ask the teachers, they don't know what is a flexion point. And it is very difficult to find out a flexion point in that particular. Only thing I have told that the advantage of vacuum is that you just exclude that it is not applied to the face and it is not applied to the ear, pinna. And rest, wherever you find out, you apply it. There is not a problem for that. Unlike forceps, you have a capellic application for that.
Sir, Dr. Monish Singh from Varanasi is asking, he's asking your preference actually, that what is your drug of choice for post-section wound discharge, if any?
Post-section wound discharge.
Yeah.
See, this I have in the previous slides I have taken it. Again, I believe in prevention. Post CS wound discharge, what should be the cause for that? Maybe that the patient factor is there, the surgeon's factor is there. Patient's factor, I know that anemia, debilitating condition, diabetic, all these, obesity, fat abdomen, all these could be one of the reasons for that. But more important is the surgeon's factor. Surgeon's factor, a good hemostasis is absolutely important. And second, I must tell that overuse of cautery. If you do an overuse of cautery is also bad. That will give a wound resistance. That's second. And suture. Earlier we are using the silk or silk as to close the suture for that abdomen. But by that we find more of infection. And if at all there is an infection, if there is a pus pockets is there, pus formation is there, we have to remove the silk, and that particular case you have to give a secondary suture for that. So we have abandoned the silk and replaced it with polyamide. 3,0-atraumatic polyamide is the best suture for skin if you are not going for a subcuticular. And subcuticular again, fine, 30 you can give it with the subcutaneous drainage or subcutaneous closure for that. But main thing, the collection is important. Second important is that while pricking the needle, at many times you find there is a bleeding and you just blindly tie it. And if the time, just instead of that, you just find out where the bleeding is and coagulate it and take a different point for that also, if it is continuing to bleed a little and now. So what I mean to say, little collection inside or bleeding or collection of blood in the subcutaneous plane is the main cause of the wound infection for that. So prevention is very important for that. Antibiotics are the least place for that as far as my knowledge goes and my experience goes. Antibiotic for our own satisfaction, we give an antibiotic according to your choice, according to your favorite company like Zuventus or some other company, and who is meeting you, for what purpose you meeting you, that is your interest and the company's interest. You can give any antibiotics. Somebody gives cefalozolin, somebody gives linezolid. This is just a guesswork for that also. So this is important. Prevention is most important for that also.
And the causative analysis, if you're done, then there is not much.
Yeah, even the cause, and if there is a anticipation like obese parietes or risk factor, you give a drain. You give a drain. I think in the drain itself also, suction drainage is much better. Romovac drainage is much better than the plain corrugated drain.
Okay, great. Sir, but you are in very high demand. You are in a real very high demand. I think
I'm an experienced, believe me, Bhupesh, I am an experienced professor.
Come on,
I have
sir.
to learn from the new generation people, new things. That's why I told you, that whatever wrong I have done for the last so many decades, I will ventilate before my death.
So, sir, a lot of doctors from various parts of India, like Jalpaiguri, Vizag, Karnal, Patiala, everywhere, they're all asking you to please continue these sessions for.
Thank you. Love me so much that I will still continue, provided the Juventus people are helping.
Well, we are always there with you.
I'm willing to continue. Then I have no objection for that, because teaching is a passion. I would have loved to see you because of the corona pandemic. I'm not able to see you, but through my lecture, I can talk with you.
Great, sir. Sir, a couple of more questions we'll take now.
Yeah.
Now, there's a question from Dr. Monish Singh again, that intraoperative, if there is a large fibroid on anterior wall extending from the fundus till lower segment with a depth of almost 7 centimeter, after which baby was extracted, how to approach such case post-operatively? Myomectomy chance possible or straight away with hysterectomy according to vitals?
Why hysterectomy? I don't consider hysterectomy because of the presence of the myoma.
Right.
Because it's not an indication. Cesarean hysterectomy should not be done in that case, in that particular case. You can do a clear, if it is a, how much, 10 centimeter myoma?
7 centimeter.
7 centimeter is a very small myoma. The largest myoma anterior wall, I have done it 30 centimeter,
Wow.
30. And it can be done. Larger the myoma, better is the procedure. Smaller the myoma, it's difficult.
Right.
Larger the myoma, you go again. If it is and upper is the myoma, little difficult because you have to give a exposure, put a speculum inside, a big speculum inside, retractor inside, and find out the upper level.
Right.
Though if it is extended to lower side, it is very easy. And believe me, larger myoma, you just do a myomectomy from inside, whole thing will be squeezed to a smaller area. The dead space will be very, very less.
Right, so there's a query from Hyderabad by Dr. Jayalakshmi, and the query is like, how to decide post-myomectomy? How do we decide at what gestational age to operate for LSCS?
Post-myomectomy. So he's undergone post-myomectomy, and what gestational age? I think this is a question same as when you go for elective cesarean section. Yeah. I think the elective cesarean section, this was very, very important in a pre-sonographic era. When we are doing a pre-sonographic era, there are a lot of cesarean section landing in iatrogenic prematurity because the dates were not being known for that. Right. Nowadays, because the many cases, the certainty of the date is known, and sonography helps in identification because in early weeks, we have shifted earlier. We are just recommending 18 to 20 weeks. TIFA scan is the prime first scan. Now 12 weeks scan, we do it for NT scan is the first. So that you know the dates, accuracy of the dates has to be done for that. Gestational age, that's number one. And leaving aside the other factors, other indications like PIH, like IUGR and other factors. If everything is normal for that, remember that at 37 weeks, we know that after 37 weeks, we can do that cesarean section for that. In post-myomectomy, what is the problem? Do you anticipate that in post-myomectomy, there is an increased chance of uterine rupture? This case particularly in post-myomectomy, the chances of uterine rupture, if you anticipate and you find that the relevant causes are there, the case has been done in some remote place, we do not know what is the status of the scar and all that, you can do at 36 weeks. Otherwise, you do it in the routine 38 weeks. There is not a problem for that also. And the case, same thing I can say that I have done a couple of cases with rupture uterus, previous rupture uterus and then cesarean section. There the question starts. Previous spontaneous silent rupture uterus at 36 weeks. I will prefer to do it earlier to 36 weeks, giving a steroid, glucocorticoids, betnesol, and then do the surgery at an earlier phase. But post-myomectomy, I think usually the scar rupture is less, and usually, therefore, the reports also says that in comparison to the cesarean scar versus myomectomy scar is a better scar as far as integrity is concerned, so that you can continue. It's the same as doing in the 38th week for that. Right. One thing I will tell you, in elective cesarean section, even if you are doing at 36, 37 weeks, it is, I may be wrong, because there I see that elective cesarean section at the borderline cases of 36, 37 weeks, I always prefer to give a betnesol, these steroid glucocorticoids, because I find that the TTN, transient tachypnea of the newborn, is more in that particular case. Normally, transient tachypnea of the newborn is more in cesarean babies, and more so in borderline cases and in diabetic mother. These are the cases where I routinely prefer to give a glucocorticoid and do it up 24 hours after the second dose. I think the TTN chance is less, so that the patient's purse is saved. Otherwise, the pediatrician will take the baby to the NICU. Baby, there won't be any problem. With 1 day and 2 days, they will keep it.
and then continue it in the ICU, and whatever the payment is there to the gynecologist, 10 times to the pediatrician they will pay it unnecessarily.
Sir, now in this continuation only, what about like if this is a twin, then
Yeah.
what is the gestational age would you prefer after post myomectomy if it's a twin?
Or twin post myomectomy. Normally in twin pregnancy, usually exceptionally when the baby size is small, there is no hydramnios, they continue up to term. Otherwise, at 36 weeks, it's an optimum period for that.
So slightly earlier. Yeah.
So earlier you do it, don't go for 38 weeks for that, because dead of night it will come again. So there I will recommend it for 36 weeks.
Okay, sir. Okay, sir. Then just give me a moment, sir. Okay, now though you have very much in detail, you have explained this, but still the query is like this, that if the bladder is adherent to lower segment, is it necessary to give incision in the lower segment?
If you are going for lower segment cesarean section, you have to go for lower segment. There is no doubt about it. And because the bladder is adherent to the lower segment, you give a classical cesarean section, I don't accept that. Because adhesion is there. Adhesion, if there is a previous cesarean section, there is some amount of adhesion is expected in to the bladder, to the lower uterine segment, So therefore, prevention, I say, in primary cesarean, when you are doing a primary cesarean section, I have seen people to over dissect the lower uterine segment, dissect the bladder unnecessarily. That don't do it. If the unnecessary dissection will be there, next time the adhesion will be much more for that. And this is a preventive aspect for that. Second important aspect is that how much distance you need for 2 layers of the closure, that's important. And that is the dissection part with them. As I have already told, don't go more than 2 centimeters below it, because the dissection is there, unnecessary oozing will be more, and unnecessary bladder injury will be more for that. And dissection always starts from the lateral to midline rather than from midline to there. And therefore, this is necessary. And if at all you find that there is a scar and below it the bladder is there, you just deliver the baby. And after delivering the baby, you catch hold of the lower uterine segment with the Ellis and then dissect it, so that it will be much more easier and the bladder is safe for that, from lateral to medial. That I have already clarified also.
Sure, sir. Right, sir. Sir, there is a query from Amravati. Dr. Alka Kute is there.
Yeah.
Now she's asking.
She's always there. Last time also. Yeah. Tell me.
Yes, sir. Will you like to advise proline suture while primary skin closure apart from subcut drain?
Proline in rectus sheath. Proline in rectus sheath.
Yeah, she's saying proline while primary skin closure apart from the subcutaneous drain.
Proline in skin.
Yes.
Or rectus.
No, she.
No, I say proline was advocated in rectus sheath for prevention of the hernia. Believe me, I'm always giving a phalansteal incision. And in phalansteal incision, secure the angle, 2 angles. And that's why in my previous recording of video, you must have seen that the angle, your side angle, you first teach it, then start from the angle. Angle secure is very important, because if at all there is a hernia in transverse incision, it is on the lateral aspect. And remember again that in some cases, the rectus muscle, if it is separated and you find a triangle lateral to the rectus muscle and laterally, there is a weak point for hernia. And before closing the rectus sheath, you just oppose this triangle, this space in the triangle, which is a weaker point. That could prevent the hernia, which I have already demonstrated in my previous videos for that. Now, rectus sheath, usually when we give a longitudinal incision in a lean, thin individual, and particularly in a pregnancy, lax abdomen and all that, and there you can give a proline. But proline for a transverse incision, I think there is not a very great advantage in comparison to our Vicryl. Vicryl is better, because the demerits of proline is that many patients which I find there is even if you find
the knots inside, they will invariably complain of persistent pain for years together on the two angles and swelling and all that. So that is a very, so even if the reactions or tissue reactions are not there, I am not in favor of proline in this particular case. Only when I'm going for a hernia repair with cesarean in the same sitting, then I will give a mace and proline. In case there are some cases which I have done it also in a hernia repair along with the cesarean section, there we give it mace and along with that the proline is given. Otherwise proline. But for skin, you can give a thin proline of 10 proline. You can give it instead of Vicryl, instead of the polyamide. But believe me, polyamide is a poor man's suture. The cost of proline and cost of polyamide is there a hell and heaven difference. So I'm always seeing the purse of the patient, and I will prefer the polyamide, 30 polyamide with reverse cutting needle. I think that's the best for skin if you're giving for a mattress suture. If you're giving for subcut, then it's different issues for that. But why you use the proline for that? Proline, you can use it, but cost factor is there for that.
Okay, sir. Then if intraperitoneal instillation of metronidazole is required post-operatively, what are your thoughts on that?
That thoughts is mainly for the, you may give it for your purpose, your interest, not for the patient's interest. Right. I'm not proposing this metronidazole instillation peritoneally. Even there is a chorioamnitis, sepsis and all that. I think simple irrigation with the ringers and all that will be enough for that. But peritoneal installation of metronidazole, I am not in favor of that. I don't have any.
Systemic is better, like IV or something is better rather than.
No, you can give an IV metronidazole. If you anticipate infection, you can give it. Sure. But why peritoneal? Peritoneal installation, I don't believe in this.
Right. Okay, sir. Then how to diagnose atypical mycobacteria, any culture test or culture? It is query from Kalyan by Dr. Santosh Chaudhary.
Yeah, I think it's more of theoretical and more of academic. If you're doing a thesis work, I will say that do a culture for that. But for clinicians like us, I think majority are clinicians. I think there is no need of a culture for that also, because in culture, most of the cases will not find. I have done a couple of cases with my postgraduate, and in culture, a typical mycobacteria is found in only 10% of the cases. 90% we do not find thing, but they very well respond to the AKT treatment for that. So for a clinician's perspective, I think research targeted for practice is not converting fully when this aspect of that. Better give it therapeutic trial.
Sir, what do you do about the dead space closure before skin closure?
Dead space closure, that's why if the skin is more, particularly the thickness is more, I don't prefer subcuticular. Okay. And subcuticular stitch versus the skin mattress, I will tell you my experience. Subcuticular stitch, immediately after the surgery, you will find that the incision is not visible. Absolutely very, very cosmetic. And in comparison to the mattress, which looks very bad immediately after surgery. But after 3 months, in a mattress suture, you cannot find this suture line. You cannot find the scar after healing. But here, you can find a thin scar and line, you can find it out. Where the other cases, the line is not found out. This is my personal experience for that. So, it is better that if a thickness is less, it is better to put a clip rather than the clip is much better than the subcuticular thing. And in the cases where you want to give a subcuticular, you have to either give a drain in the subcutaneous space or close the subcutaneous one layer, you give it subcutaneous and then close it with that. If you keep it open, I think more chance of infection will be there for that.
Sure. Sir, again, Professor Dr. Indra Bhati is saying that do you have or have you ever had difficulty in delivering the baby due to huge posterior cervical fibroid pushing the baby's head high up?
Yeah. I think I remember I've experienced that long back when there's a huge fibroid and head is mainly I could find the head in the around the umbilicus. So there is a lot of difficulty in that, and that is the case where the vacuum extraction is much more. You cannot deliver it by hand. So that particular case, because of the vacuum, I could deliver it for that, and then I did a myomectomy after that.
You push the mass on one side.
Pardon?
You push the mass with the hand and then put the
yeah, because it has gone up to the level of the umbilicus.
Right.
So one fundal pressure will be there. After incision, you apply the ventouse, and then ventouse will be helpful for that.
Sir, this is a query from Bhubaneswar. Dr. Smruti Shri Sahu is there.
Yes.
She's saying a large, approximately 12 by 12 centimeter myoma at posterior lateral wall, sorry, and intraoperative found to extend up to submucosa with degeneration. Intraoperative patient had no PPH, 8 to 9 hour. Post-op patient had PPH, and on her per vaginal examination, fibroid was found to protrude more into cavity with intermittent bleeding. So she's asking, sir, how shall we manage the case?
I think that that is a usual sequence for that. Immediately after delivery, if you find during intraoperative period that you have found that there is a submucosal component, I think it's easier to do a myomectomy through the cavity. I think it's much better. Otherwise, if there is a submucous component after delivery, within few days, the uterine muscle contraction will push it more, and it will come through the to enter into the cavity, giving rise to bleeding, giving rise to giving rise to terrible pain, because it will form like a polyp, myomatous polyp coming out of the cervix for that. And second important thing is that might confuse you as retained placental tissue by ultrasound. So I have seen a couple of cases where there was a myoma and placental tissue was there, and it was thought that it's a placental tissue, but on exploration nothing could come out. Patient is having bleeding, but it is a case of, ultimately came out to be a case of submucous myoma. And I remember one case, this particular case has filed a case, medical negligence in the consumer court against that concerned doctor, who is my patient, my student. And then when he came to me, and in the court of law, then I said that this was the situation. I handled this. This is a case of submucous myoma. Why? Because the case was filed that the doctor has left the placenta inside, leaving at the sonography report. So I will recommend in that particular case, doing in the same sitting, intracavitary would be much more better for that.
Correct. So there's a query from Chennai again, that there's a pregnancy with past history of sudden IUD unknown cause. Now when is it okay to deliver her? Is it wise to do elective LSCS or allow her further beyond 36 weeks with close monitoring? What is your experience on that, sir?
My experience or my protocol is that I will find out the possible causes why there is an intrauterine death. And suppose there is a 36 weeks, there is a IUD. In that particular case, main cause, the commoner conditions I will find out, and the cause of the intrauterine death. If a common cause is found out, suppose a case of PIH is detected or premature rupture of membrane is found out to be that, then there is not a problem. If the normotensive and there is no leaking, will continue treat it as normal and continue up to term also for that. If there is an unexplained cause for that, unexplained, these are not one, couple of cases of unexplained IUDs I have seen it. In that particular case, my preference would be to interfere 1 week before the expected period of death. Suppose the IUD has occurred in 36 weeks, I will interfere at 35 weeks and deliver it in that particular moment. Otherwise, it will be a real problem for that. And giving a steroid also for that.
Yeah, so history will guide us accordingly.
Yeah. And particularly if there is an unexplained more than one deaths at a particular interval,
Right.
That is the protocol. Suppose unexplained in IUDs at 36 weeks and 2-3 deaths are there. I will definitely do it if everything goes well 1 week before that, or if everything comes, there is a problem even before that also I will do it. I will not prolong it. But one death, if everything now goes with the risk, I can continue up to 37 weeks.
Sir, again a query from Odisha, Dr. Sanjay Kumar Khamari. Question is that though you have, I think 2-3 times you have given this explanation again, but slightly more elaboration may be required in this case. That if in the previous cesarean section we are giving incision over scar, should we excise the scar tissue to the whole depth, or should we leave it on a superficial?
Yeah, that is a discussion. In my previous episode also, this I have discussed this.
Yeah.
Now, scar is a various types. If you find a scar which is a very thick fibrous scar, and where you expect that again suturing that the healing will be a problem. I have seen a fibrous scar and healing will be a problem. There you excise the scar. Otherwise, scar excision is not at all necessary for that. Right. Don't excise the scar. If you only fibrous scar, thin scar, but fibrous, you excise it.
Yeah. Okay. So I think, sir, this will continue, but I'm just taking the last query now for you. This is from from Anakapalli. Dr. Prasanna Lakshmi is there.
Yeah.
Saying that LSCS wound closed subcutaneously with Vicryl on the 7th POD, wound healthy, but a tinge of purulent discharge from the angle, no induration of the wound, but skin appears edematous. Do you think that wound to be opened, or we don't touch it?
Don't interfere unnecessarily. More of interference early will be difficult for that. If that's a oozing and the wound is there is a slight edema and there is no induration, much of induration, leave it as such. God will take care of that. Give some antibiotics. You can do a culture also of the discharge, and appropriate antibiotic you can give it, and just observe. There is not at all a problem. Majority will heal it of its own. If you manipulate, more problem will be there.
Right, sir. And sir, there is one question which I don't want to miss, sir, because it is related to fetal movement. So I just ask one more question from you. He's saying that, do you have any experience of patients complaining of less fetal movement after getting betnisol injection?
Less fetal movement after betnisol. Betnisol injection, particularly if a known diabetic, I want to give a betnisol. She was suppose on insulin, and definitely the blood sugar will rise. And those cases where this type of experience I've got it, fetal movement, decreased fetal movement I've observed. But after a betnisol, on normal cases, I have no experience of decreased fetal movement. But
probably she is doing lung maturity. Sorry.
Decreased fetal movement is not to be taken lightly. That thing is very important. So even if we have gadgets, I will prefer the clinical things much more importance to the gadgets for that. Because I have seen if the patient is able to appreciate the fetal movement and now suddenly finds fetal movement as not seen, even if other things are normal, I will not take lightly. I will take seriously for that. Because I have seen many cases where ultrasound movement is there, ultrasound, there is a lot, Leica is good, and the patient is suddenly tells that my movement is decreasing. I have operated. Immediately decision to be taken as cesarean section. I find deep meconium stent Leica. Plenty of Leica, but deep meconium stent. Had I left it, it could have been a problem for that. So this, even if betnisol or without betnisol or with betnisol, I think the movement is very, very important. Don't ignore that.
Okay. All right, viewers. So I think it was a very, very interesting session with our revered Dr. Mahapatro, and we have really enjoyed this whole session.
Thank you, everyone.
So, And one more small announcement I want to make over here, that if anybody of you want to have the recording of the previous sessions, please send your email to, I'll give you an email ID over here. It is Aditya, that is Aditya, Aditya dot Bordolai, that is Bordoloi @Zuventus.com. So I repeat the email ID, aditya.bordolai, that is Bordoloi @Zuventus.com. So with this, we thank you very much, sir, and all the audience who were there with us during this session. Thank you very much. Sir.
Thank you. Thank you very much. Thank you, Allah. Thank you, Devan. Thank you, everybody. Thank you, the team.
Thank you, sir. Thank you so much. This time it was absolutely flawless, sir. In this terms of video,
I wanted flawless things.
And the lag time was also minimal. There was no lag time. मतलब जैसे आप